Hi, good afternoon. I am Dr. G.P. Ratnaparkhi, Intervention Cardiologist from city of Mumbai. Today, my topic is the current status of antiplatelet therapy in acute coronary syndrome. Acute coronary syndrome is because of the plaque rupture which invites various rheological reactions and actions. So, ultimately there is a thrombus formation. That is the reason why antiplatelet therapy plays a corner stone in the management of acute coronary syndrome. Here we have a very few drugs which are acting as antiplatelet therapy which are currently used. First, start with aspirin. Aspirin as an antiplatelet therapy in acute coronary syndrome enjoys the monopoly last 50 years because almost more than 280 trials of more than 3.5 lakhs patient shows that there is significant reduction in mortality, morbidity and MACE. Almost 25% reduction in the strokes and myocardial infarctions and 16% reduction in the mortality. Although it has so many side effects, almost 10% will have GI side effects. Out of that, important is 25% to 35% patient will get resistance to the aspirin. In such situations, the chances of stent thrombosis or recurrent episodes are very high. So, next comes into the picture is a clopidogrel. Again, it's a modest antiplatelet therapy, but definitely potent than the aspirin. If we combine aspirin with the clopidogrel, there is additional 7 to 10% reduction in the MACE. Again, clopidogrel has its own drawbacks. It is a modest antiplatelet therapy and carries very significant interpatient variability. You will not get the same effect with the clopidogrel in all the patients. So, significant interpatient variability, and again resistance to the clopidogrel is found in 20 to 25% of the patients. So, we were in the search of the molecule which will have a great response, great platelet inhibitions. So, we turn towards the P2Y12 inhibitors. Two drugs are there available right now in the clinical scenario, that is prasugrel. Trial Triton TIMI 38 shows there is significant reduction in the MACE when compared with clopidogrel. This reduction of MACE was found slightly on the cost of increased bleeding, but particularly there are 4 subsets where we strongly recommend prasugrel or other antiplatelet therapy. That is, if there is recurrent ischemic events, patient is diabetic, if there is tremendous load of the thrombus in the coronary arteries, and last, if there is stent stenosis or stent thrombosis. In these 4 situations, prasugrel should be indicated. As with the prasugrel, there is increased bleeding chances. So, next year there was a new molecule come into the picture, come into the clinical situation, that is ticagrelor. The trial Plateau has shown significant benefits in reduction of MACE with negligible increase in the bleeding tendency. The bleeding tendency is comparable with the aspirin or clopidogrel. So, we got a drug which has shown improvement in the MACE, but without added antiplatelet therapy. So, this is what a journey of antiplatelet therapy last 50 years. Now, all the guidelines are mentioning in acute coronary syndrome the use of aspirin around 75 mg with P2Y12 inhibitor, that is prasugrel or ticagrelor for 1 year, and thereafter we have to continue either single antiplatelet therapy or DAPT, seeing the clinical profile of the patient. Thank you very much.